Hello and welcome to ERPM Notlog. Today I will be teaching you about acute appendicitis. Appendicitis is the inflammation of the vestigial vermiform appendix and is the most common cause for urgent abdominal surgery. Commonly occurs in patients in their early teens to early 20s. If you like our videos, please subscribe and press the bell icon so that you will be able to see the latest videos as they are uploaded. This slide shows how the location of the appendix varies in people. Retrocecal is the most common and post-ileal is the least common. Etiology: obstruction of the lumen of the appendix by fecolith, stricture, parasites, particularly Oxyuris vermicularis, which is commonly known as pinworm, carcinoma cecum. It's an occasional cause in middle-aged and elderly patients. Infection, possibly viral, and rarely a foreign body. It is rare in elderly because of narrow appendicular lumen and rare in children because appendicular lumen is too wide. In children, the diagnosis is delayed because of low suspicion. The risk of perforation is high. Diffuse peritonitis can occur rapidly due to the great omentum being underdeveloped and is unable to localize the infection properly. In elderly, due to reduced inflammatory response, the findings in history and examination is less remarkable. They sometimes delay in seeking medical care. They have a considerably higher risk of perforation at presentation. The risk factors for perforation are immunosuppression, extremes of age, obstruction by fecolith, diabetes mellitus, previous surgery of the abdomen, and pelvic appendix. Great threat of appendicitis is the potential for diffuse peritonitis. Clinical features: the symptoms are abdominal pain, initially periumbilical pain, which shifts to the right iliac fossa within 24 hours. Anorexia is an important clinical feature, especially in children. Nausea and vomiting usually occurs once. Signs: the cardinal features are unwell patient with low-grade fever, localized tenderness in the abdomen, which is maximum at McBurney's point. If diffuse, then it suggests peritonitis. Abdominal guarding and rebound tenderness, which can be elicited after asking the patient to cough. This diagram shows the location of the McBurney's point. Rovsing's sign: deep palpation of the left iliac fossa causes pain in the right iliac fossa. Pointing sign: ask the patient to point at where the pain began and where it radiates. Psoas sign: sometimes an inflamed appendix will lie on the psoas muscle and the patient, usually a young adult, will lie with the right hip flexed for relief of pain. Psoas sign is elicited when the pain occurs after hip is flexed against resistance or hyperextension of the hip. Obturator sign: flex the hip and internally rotate. This will stretch the obturator internus muscle, and if the inflamed appendix is in contact with it, this will cause pain in the hypogastrium. Differential diagnosis: in children, it can be gastroenteritis, Mecker's diverticulitis, and mesenteric adenitis. In adults, it can be ureteric colic, Crohn's disease, and torsion of the testis. In the female adult, it can be Mittelsmans, ectopic pregnancy, or pelvic inflammatory disease. In the elderly, it can be diverticulitis, carcinoma colon, and leaking aortic aneurysm. Investigations. Diagnosis of acute appendicitis is clinical. There are certain scoring systems that aid diagnosis. This is one such scoring system, the Alvarado score. A score of 7 or more strongly predicts acute appendicitis. If the patient gets an equivocal score, ultrasound abdomen or CECT can be done to confirm the diagnosis. Pre-operative investigations. The routine investigations are full blood count, urine full report to detect microscopic hematuria, which usually occurs in pelvic appendicitis, calculi, and urinary tract infection. The selective investigations are urine beta HCG. Urgent beta HCG is done to detect ectopic pregnancy. Supine abdominal X-ray, X-ray KUB, is done to detect calculi. Ultrasound abdomen or pelvis is done to rule out gynecological causes such as ectopic pregnancy. CECT abdomen is commonly done in children and elderly if diagnosis is doubtful. Treatment. IV antibiotics such as cefuroxime and metronidazole. Appendicectomy is done as an open or laparoscopic procedure. If appendix is perforated, give IV antibiotics and do a laparotomy. If there is an appendicular mass and if the patient is stable, the Ochsner-Sharon regimen is followed. Antibiotic therapy is given. Give the patient plenty of bed rest. Record pulse rate, blood pressure, respiratory rate, and temperature every 4 hours. Record the size of the mass daily. Keep the patient nil per oral. Maintain the fluid balance of the patient. If the patient deteriorates, an exploratory laparotomy is done. If the patient's symptoms settle down, an internal appendicectomy is done. Ask the patient to come 6 weeks to 3 months later and then operate. Indications of deterioration: rising pulse rate, increase in size of the mass, increase or spread of pain abdomen. If there is failure of resolution of an appendicular mass or continued increase of fever, indicates that there is pus within the appendicular mass. This abscess can be drained percutaneously under the guidance of CT or ultrasound. Also, it can be drained by an open or laparoscopic procedure. IV antibiotics should be given. Thank you for watching our video. If you like the content, please like and subscribe.